Good morning, everyone. My name is George Graham II, and I would like to welcome everyone to the Real Men Talk Just for the Health of It discussion panel. I am a proud member of the Conway Myrtle Beach Alumni Chapter of Kappa Alpha Psi Fraternity Incorporated. Kappa Alpha Psi, a college fraternity, now comprised of functioning undergraduate and alumni chapters on major campuses and in cities throughout the country, is a crystallization of a dream. It is the beautiful realization of a vision shared commonly by the late revered founders Elder Watson Diggs, John Milton Lee, Byron Kenneth Armstrong, Guy Levis Grant, Ezra D. Alexander, Henry Turner Asher, Marcus Peter Blakemore, Paul Wayman Kane, Edward Giles Irvin, and George Wesley Edmonds. It was a vision of these stout men that enabled them in the school year 1910 to 1911, more specifically, the night of January 5th, 1911, on the campus of Indiana University at Bloomington, Indiana, to sow the seed of a fraternal tree whose fruit is available to and now enjoyed by college men everywhere, regardless of their color, religion, or national origin. The Conway Myrtle Beach Alumni Chapter was chartered on August 8th, 1970. The charter was granted to brothers Franklin R. DeWitt, Gilbert Ellaby, Ralph Graham, James E. Lee, James T. McCrae, Leroy Rainbow, Albert Rue, Theron Shields, Cleveland Stevens, James Z. Spain, and J.R. Taylor. The chapter changed its name on November 13, 1999 to the Conway Myrtle Beach Alumni Chapter. The Conway Myrtle Beach Alumni Chapter has dedicated ourselves to spreading awareness about a silent killer in the male community, prostate cancer. The month of September, or as we now affectionately call it, Nooptember, has been a month of community engagement. We first started with the Brothers Only Cookout. At this cookout, we discussed prostate cancer and men's health. As my great auntie Chuya used to say, you must sweep around your own doorstep before you can tend to another neighbor's yard. Next, we had a fish fry, where we not only fed the community's hunger for food, but also piqued their interest about prostate cancer awareness. I see a few familiar faces in here today. Thank you for coming out. Next, CMB went blue. We thank everyone who supported sending in pictures of them wearing blue on September 15th to increase the visibility about prostate cancer awareness. Now today we're here for our final event of Nooptember, as we have a discussion talk, Real Men Talk Just for the Health of It. Here we will discuss prostate cancer, how to maintain a healthy prostate, treatments, and much, much more. Now, I'm not here by myself. I have a special friend here with me today who has helped me throughout this discussion panel, Ms. Promise Scott.
Good morning. How are you all? My name is Promise Scott. I'm an SCNM student, and I'm just happy to be here with you all today.
Now, Promise, I know that you said that you're happy to be here, but why? This is a men's talk. Why are you here today?
I'm here because at SCNM, we were studying prostate cancer, and you happened to contact me, and I'm so ecstatic to be here because men's health is also important. Yes, I'm a female, but I have a father. As women, we have sons and we have uncles and cousins, and so this is something that's really important overall. So that's why I'm here.
Now, today we have a great panel lined up for you guys. Of course, due to COVID and due to everyone being pulled in many different ways, we actually had to do this pre-recorded. So everyone that you're seeing has been pre-recorded. I see that we have Mr. Cox here with us today as well. He's the only one who I think who's in here today who will actually be live. But to give you a little bit of information on those who you will be hearing from, we will first start off with Dr. Darrell Hall. Dr. Darrell Hall is a practicing anesthesiologist in Atlanta, Georgia. He resides with his wife, Sakita Hall, and two children, Camden and Blake Hall. Dr. Hall is the medical director of the Department of Anesthesia at Piedmont Henry Hospital in Stockbridge, Georgia. He is also the medical doctor of Lexington Plastics in Atlanta, Georgia. As a son of Louisiana, he was born and raised in Baton Rouge, Louisiana, and is the son of the late Dr. David Hall Sr. Dr. David Hall Sr. was a 1964 initiate of the Alpha Sigma chapter of Kappa Alpha Psi Fraternity Incorporated. Dr. Hall graduated Morehouse College in 2002 with his Bachelor of Arts in Psychology and received his medical doctorate at, at Meharry Medical College in Nashville, Tennessee. In between college and medical school, Dr. Hall was a 2003 initiate of the Baton Rouge Alumni Chapter of Kappa Alpha Psi Fraternity Incorporated. While at Meharry, Dr. Hall served many different positions, finally serving as a poll marker of the chapter in 2008. Dr. Hall enjoys spending time with his family and being active in the community. He is on the board of trustees at Impact Worship Church in Melbourne, Georgia. He is passionate about playing poker and sports, especially Florida State University and Saints football. He loves to travel and share a good joke. Ultimately, he hopes to help inspire and help people of color to embrace their health and not let unknown fears be a burden and hurdle for a healthy future. That is Dr. Darrell Hall.
Okay, so next I will be introducing Dr. Winston D. McIver Jr. He is a native of Horry County, having been reared and attended public school in Conway. He is the oldest child of attorney and Mrs. Winston D. McIver Sr. He is a 1987 honors graduate from Conway High School, as well as a 1991 cum laude graduate from Morehouse College in Atlanta, Georgia, receiving a Bachelor's of Science degree in psychology and pre-med. Dr. McIver was awarded his medical doctorate degree from Meharry Medical College in Nashville, Tennessee in 1997. He received numerous awards and recognition during his years in medical school. Dr. McIver finished his internship and residency in family medicine at the Palmetto Richland Memorial Hospital, University of South Carolina in Columbia, South Carolina. While in residency, he was recognized for outstanding work and dedication to his residency program. During his residency, he was given the Thomas H. House Award, which is a highly coveted award that recognizes the most compassionate resident physician. Dr. McIver furthered his education by becoming certified in a postdoctoral program, sports counseling from California University of Pennsylvania. Dr. McIver was also awarded the prestigious Dr. David Satcher Fellowship to receive additional medical training at Case Western Reserve University in Cleveland, Ohio. Dr. McIver is a member of numerous medical organizations, which include the American Academy of Family Physicians, the American Medical Association, American College of Sports Medicine, and the Palmetto Medical, Dental, and Pharmacy Association. Dr. McIver is a family physician who has an interest in adolescents, adults, and the elderly. He also has a strong interest in hypertension, diabetes, sports-related injuries, and preventative medicine. Dr. McIver is located at the Walk-A-Mile Primary Care, LLC, located at 660 Singleton Ridge Road in Conway. He is married to attorney Angela Graham McIver, and they have 3 little girls, London Amaya, Layla Aaliyah, and Logan Abraya. Other affiliations include, but aren't limited to, former board member of Walk-A-Mile Center Mental Health, former board of the March of Dimes, past president and board member of 100 Black Men of Myrtle Beach, athletic medical director and team physician for the Coastal Carolina University Department of Athletics, member of Friendship Missionary Baptist Church, advisor to health ministry team at Friendship Missionary Baptist Church, medical supervisor for Coastal Carolina University Student Health Services, shared care participant physician, medical consultant for concussion management for all of Horry County and school athletic department, member of Kappa Alpha Psi fraternity, deacon at Friendship Missionary Baptist Church, RAP partner at Whitmore Middle, volunteer physicals for student athletics at Horry County Schools, CEO and owner of Walk-A-Mile Primary Care, CEO and owner of MacGyver Medical Consulting, and co-owner of MBW Land Partners. Some of his interests are jazz music, traveling, golf, and daddy-daughter time.
Next, we have Dr. Cedric McFadden. Dr. Cedric McFadden is a surgeon, speaker, writer, and mentor. He is a board-certified colorectal and general surgeon and teaches as a clinical assistant professor of surgery. He treats a wide range of disorders of the large intestine, including colorectal cancer, inflammatory bowel disease, diverticular disease, and hemorrhoids. He performs colonoscopies, minimally invasive surgeries, and robotic surgery. He has nationally lectured to hospitals, civic organizations, churches, and community groups. Dr. McFadden graduated with honors from Xavier University of Louisiana in New Orleans and earned his medical degree from Temple University School of Medicine in Philadelphia. His medical training include a residency in general surgery from the Greenville Health Systems and the University of South Carolina, Greenville, and a fellowship in colon and rectal surgery from the Georgia Colon and Rectal Clinic in Atlanta, Georgia. He is a member of the American Society of Colon and Rectal Surgery and American College of Surgery. He is also a member of the National Medical Association and Society of Black Academic Surgeons, Association of Healthcare Journalists, and the National Association of Black Journalists. Dr. Cedric McFadden regularly appears on an on-air health expert as an on-air health expert on both television and radio. He is currently a medical contributor to CBS WPSA 7 News in upstate South Carolina. He has appeared on CBS, Fox, NBC, MSNBC, and his advice has been featured in Dr. Oz, The Good Life, FoxNews.com, Essence Magazine, Reader's Digest Prevention, Shape Magazine, and BlackDoctor.org. His blogs have been published on KevinMD.com. He is also a mentor to college students, medical students, and surgical residents. He is a Liberty Fellow and a member of the Aspen Global Leadership Network. Dr. Cedric McFadden lives outside of Greenville, South Carolina with his family. He is a runner and a singer. Dr. Cedric McFadden.
The next we'll have Dr. Havens. Dr. Havens is a naturopathic physician and clinical researcher whose practice focuses on evidence-based precision, complementary, and integrative oncology. She uses next-generation sequencing and multi-platform tumor biomarker analysis to inform treatment recommendations tailored specifically for each patient's cancer. Prior to becoming a naturopathic physician, Dr. Haven received her doctoral training at the University of Virginia in the Department of Molecular and Cancer Biology in Charlottesville, Virginia, after which she continued as a researcher specializing in molecular diagnostic for the Department of Veteran Affairs in Little Rock, Arkansas. Her background in cancer biology and genomics, coupled with her training in naturopathic oncology, makes her uniquely qualified to deliver patient-centric precision integrative cancer care. Her area of focus is oncology. Her education consists of a doctorate of naturopathic medicine in 2015 at Southwest College of Naturopathic Medicine and Health Sciences. Also, a NIH and NRSA clinical research fellowship at the University of Washington. She also received clinical training as a resident naturopathic oncology at the Cancer Treatment Centers of America in Philadelphia, Pennsylvania.
Good morning, Dr. Hall. How are you doing?
Good, Brother Graham, good.
Okay, so I just have a few questions about maintaining a healthy prostate. How can I maintain a healthy prostate?
So maintaining a healthy prostate, first and foremost, you need to understand what are your risks. And I don't want to bury the lead of jumping into the talk of prostate cancer, but understanding your risks. First thing, like most disease processes, good health habits increase your healthiness, and that's low. Trying to minimize your saturated fats in your diet, trying to eliminate as much animal products as possible, like processed meats and things like that, that could increase your risk for prostate cancer. So things like broccoli, things like cauliflower have been known to show to help have some levels of assistance and protectiveness in prostate health.
So wait, Dr. Hall, I am low-key a carnivore. I enjoy eating a good steak. Does that mean I'm not allowed to have a good steak?
No, everything's in moderation. It's not the person who goes and gets the porterhouse just because it's the 4th of July. It's the guy who eats 6 out of 7 days, 6-pack of beer, fried chicken, and a steak. That's the person that needs to kind of watch their health and watch their nutrition, because it's been shown that people who have low vegetable fruit intake are at higher risk for prostate cancer. Things like cigarette smoke, they've been shown to have some lines of connection between cigarette smoke and prostate cancer, as well as also family history. More than likely, most people who hear this, as a proud member of Kappa Alpha Psi Fraternity Incorporated, most of us are African American. We win the lottery on a lot of genetic things, but prostate health is not usually one of them. We are at higher risk for it. So understanding that risk when you walk into the building, when you wake up, that helps you, because you're not going to be shocked if someone tells you something's going on with your prostate, because somebody in our families had it. So someone we've known close to us has had prostate disease. So we're more well balanced to be around it, and knowledge is half the battle.
So are there any supplements that I can take to increase me having a healthy prostate? So
bad news is there's been no supplements that have found to help prevent prostate cancer. Saw palmetto, especially named after kind of like the palmetto tree over there in South Carolina, has been used to treat BPH, which is benign prostatic hyperplasia, so a bigger prostate, but that's not prostate cancer. It's 2 different disease processes. So it's been shown to maybe help with that, but there's no supplements have been shown, and I say being shown, that has been tested and have been proven to have a positive link to decreased risk. And no supplements have said that. You go to your GNC, you'll go to Vitamin Plus place, and they'll say this is for prostate health. It's more for general health. It's not to decrease your prostate cancer risks.
So I know that eating healthy is a big part. Are there any other preventative care methods that I can take to have a healthy prostate?
When I say eating healthy, and that's, you want to decrease, ultimately you want to decrease your risk factors. And obesity has been seen to increase to worsen your prognosis of cancer. Doesn't necessarily lead you to that bridge of cancer, but those who have prostate cancer have a worse course if they're obese or morbid obese. So that's one aspect of looking at diet going into prostate health. Also, being in better shape, having more strenuous activity decreases your risk of forming prostate cancer. So on both sides of the issue, if you want to look at prevention, and prevention is the golden ticket in medicine, because we don't really do a good job of prevention. Especially us as men, we work, we break down. And then when you go to the doctor, you've already broke down. You're at high risk for pneumonias, you're at high risk for being admitted because, your appendix is now gone, or your heart. And so now you're having a separate disease process and your body's breaking down. It's tough to get back up from that breakdown, because it's not going to just be one issue. It's going to be your heart, your liver, your kidney. It's not going to just be, or your heart, your lungs. it's not going to just be one issue when it could have been one issue along the way. And prevention would be making sure you monitor all of those organs so you don't have that breakdown. You don't want to take your car into the shop when the engine and the transmission is bad, and all you could have done is oil changes along the way, and you check your fluid every 30,000 miles, and you wouldn't have it break down. Your body's the same way.
I understand that. So, being a male, we don't go to the doctor like we should. So we wait until that check engine light comes on before we actually go to the doctor.
Yep.
How can I talk to my primary care physician about my prostate?
So first and foremost, the primary care doctor is there for you. He's your link. He is your yogi to help unleash your full potential, in essence, right? They wouldn't be there if you weren't in the room with them. So if you can't talk to your primary care, you're already one step behind, because they have pamphlets galore. They're there to help give you information, and things that they don't know, they'll find out and get back to you. And so they're your liaison around the healthcare pantheon of things going on. You're not going to go in there and go find a kidney doctor. You got to go through your PCP first. And so even like with a urologist for prostate health, you have to get in those doors. And when you get in those doors, it opens all the other doors of your health. And by just having the dialogue that we're doing right now, you tell your concerns, your fears, your good safety habits, or your good healthy habits, and it becomes this dialogue where it shouldn't be you sitting in the principal's office and they're telling you what you did wrong. It should be a dialogue.
Now, I know that myself, I'm 32.
Mm-hmm.
I'm scared to get my prostate checked because I heard it's painful. When should I actually go about getting my prostate checked, and what is the process behind it?
All right, so that is a great question, and it's so great that all of the various societies that deal with health, prostate health, and from like the American Medical Academy to AUA, which is a urologist board, they all have a slight difference of their opinion. Because first and foremost, we got to talk about the incidence and prevalence of this disease process to get into that information. So the peak onset of prostate cancer is around 65 years old, right? If you go across all ethnicities in this country, you see that peak around 65. We've already talked about high risk, and look around, look to your right, look to your left, look to your right. That's where we are. We are part of the high risk people. So what else increases that risk for screening purposes? First degree relatives, that's fathers, brothers. Did they have prostate cancer? And if they did, what age? So what these boards are saying, 65 or younger is if when they start developing prostate cancer, then you need to be checked early. And why do they say that? Let's go back to what we were just saying. 65 is the peak. So that's when you start to see the proliferation the most. And then afterwards, you need to be checked before that, right? And so if your pops had prostate cancer at 55, before 55, you need to get checked.
I understand that.
So on average, they say to start screening from 50 to 55 is the kind of gold standard. That's kind of standardized across all races, all kind of spectrums. But again, I'm talking to a predominantly African American audience, so 50 is probably your gold number. But 45 to 50, if you are very high risk, that means your father died from prostate cancer, was diagnosed extremely early. You've had female relatives or male relatives who had BRCA. That's a buzzword nowadays, a genetic test for breast cancer and ovarian cancer, if they pass from that. If they've died at an early age from that, there's been a link to that BRCA gene with prostate cancer also. So if you've had family members who've died early from some of those cancers, then you need to look at that 40 to 45, more than likely that 45 to 50 group of getting screened at that time. Also, if you're having symptoms, and what are symptoms of prostate cancer? The bad news is one symptom is there is none. Two, vague hip pain, back pain can be a symptom. Painful ejaculation, painful urination are all symptoms of prostate cancer. All blood in the semen, blood in the urine also is a symptom. So we talked about screening as far as the age. Now let's kind of demystify what's going on when you go to the doctor.
Right.
So now so I'm gonna speak for myself. My father, I think, got diagnosed with prostate cancer at 68. I'm African American male, so I am high risk, obviously. My father had a little bit past that peak age, so I went to, and I have a beautiful wife from the state of South Carolina who made me go to my family medicine doctor and made me get tested, or made me talk to him about getting tested. And he's like, I'm a little early, and we had the dialogue back and forth and talking about the health, talking about our risk factors. And he was like, I usually do my patients at 45, and I'm 41. Well, I'll be 41 on Saturday. So,
happy early birthday.
Sunday the 12th. So,
happy early birthday.
I appreciate it. So I was a little bit early, but what the test is, for most family medicine doctors, internal medicine doctors nowadays, they do what's called a PSA, or prostate specific antigen. And it's a little bit of a misnomer because it's not a very specific test.
Okay.
But the name is PSA, as on prostate specific. And that number is basically from 0 to greater. I mean, 7-ish is a high number, but also it's standardized per your age and your ethnicity to some degree. Okay. So if you're in your 40s to 50s and you're above 2.5 as an African American, they're going to send you to the urologist. All right. If you're in your 50s to 60s and it's above 3 to 4, they're going to send you to the urologist. If you're in your 60s and it's above 5, they'll send you to the urologist. So if you're a young man, 40 years old, and it's 6, they're sending you to the urologist for further testing. Okay. So the number doesn't tell you everything, but the number kind of gets you in the ballpark. So it's a blood test. They draw it out one of your veins and they send it to the lab. And there are some clinicians, some family medicine doctors, internal medicine doctors that will do something called the digital rectal exam. And that's the one thing as us men we're scared of. We kind of do ourselves a disservice because our girlfriends, our moms, our wives have been having pap smears all their life. They've been having mammograms and breast exams since the age of 30 or 35, 40, and all of a sudden we get 45 and good Lord, it's time for us to get really intimate with the doctor.
Right.
What I'll say is this: first things first, fear is no way to live, and ignorance is the easy way to the grave. And for most clinicians, looking at a patient or doing a digital rectal exam is like looking at their elbow. It's everyday hat. And for us, it's the biggest day of our lives. Mm-hmm. And they really shouldn't be, because there will be some emotional discomfort more than physical pain. Okay. Because it's like, how we're talking to a girl in the yard or whatever, and we're trying to get someone's number and it's a special occasion, trying to get it done. But we feel like we have to do certain things to have our success. But it's not like buying someone a dinner. You're going to have the exam. It is a scientific kind of thing. It's a clinical thing. And the urologist is trying to, or the family medicine doctor is trying to feel how the prostate feels itself. Is it boggy? Is it hard? Is it kind of like, is it asymmetric to see if there's a nodule? All that gives them information to determine, do you get a biopsy or not?
Understand.
And so a lot of it is uncomfortable because it's outside of our normal, but it's a necessary part of learning about your prostate health.
So now you mentioned the PSA exam.
Mhm.
What are the risks and benefits of the PSA test?
So as a blood test, the risks are relatively low. The benefit is to kind of screen you, to kind of get you to know exactly where on the pantheon of, are my high risk, am I moderate risk, am I low risk, and kind of the numbers I was telling you for age earlier. But again, it's called that specific, but it's not, because you can have elevated PSA levels for many different reasons. One, something called, like I mentioned, BPH, a bigger prostate, that can cause that level to be higher. If you had a Foley for a procedure, or that can raise it. If you had a prostate biopsy, that can raise it. If you have something called prostatitis, which is an inflammation or infection of your prostate, that can raise it. So there's a lot of stuff that we haven't mentioned prostate cancer that can raise your PSA number. But a but most prostate cancers do raise that PSA number. So it's a blood test. They draw it, they send it off, and they give you that number. And so that's the benefit. The benefit says, hey, this guy is probably a high possibility, high probability for them to have cancer. So then the next step is to go get that prostate biopsy. Or this patient is a low probability of having prostate cancer. We'll watch them. We'll draw in another 2 years or 1 year, depending on what the physician desires to do.
Understand.
So, and the one kind of drawback is there are enough people who have a higher PSA number for those reasons that we mentioned, as far as the other reasons why it could be high, that you may get a biopsy and you may not have prostate cancer. So it's what people say in the industry, a high false positive rate, because it's saying that you may have the disease, but you may actually not at the same time. And so some fear and some apprehension goes along with that PSA number, because it's not definitive.
Okay, I have a question for you.
Feel free.
So you spoke earlier about men being afraid of the digital exam.
Mhm.
There are the mothers, their daughters, their sons who are in the audience right now. What can we do to, or how can we convince more men to go to the doctor, in your opinion?
So we mentioned prevention earlier, and you know, brothers, we are interesting people. We are interesting guys. We are so strong. My bishop all the time says, you know, no one goes into the house and says, man, look at that foundation. They look at the fancy stuff. They look at the windows. They look at the rooms. But we as men are foundation. We're the foundation to our families. We're the foundation to our communities. We are the foundation. And the problem with not, when the house's foundation is crumbling, the whole house falls. And so it's imperative that us as men, especially African American men, go see our clinicians, our physicians. You know, we can go to the barbershop twice a week sometimes. We can go to the gym and work out, go hoop, or whatever we do. But part of body health, part of mental health, is going to see your physician too. You can't have complete health. You can pump all the iron you want, but without going to having regular checkups, that's one facet of health. And I think a lot of us really miss that we feel like we're good if we can bench press 250.
Right.
But my heart rate may be 120 and on baseline, and my heart's crapping out. And so our beach bodies may be great, but our insides may be rotten to the core. And the only way you can make sure that you optimize that is by eating right, going to the physician, exercising. And so to get people to go back to the question, how do we get people, African American men, we have to get past that stigma of Tuskegee. We have to get past the stigma of no one's out there for us. You may have to find someone who you feel you have that relationship with, someone who may look like you, maybe someone who's from your neighborhood, who may have gone on to become a physician, or someone that they recommend. But ultimately, you have to find someone who speaks your language, and by doing that, you can then help grasp people who are out and to come back and to try to get healthy. And that's one bridge to get there. It's just, you have to make the effort. I mean, if I can leave with one more word, is make sure you're seen. Go see your primary care doctor if you're having questions about your prostate health. Make sure brothers talk about this kind of stuff with each other, and we can demythify this together, that it's nothing that we can't do together.
And we're here with Dr. Winston McIver Jr. Dr. Mack, can I call you Dr. Mack?
You sure can.
Dr. Mack, how are you doing today?
Doing great. Doing this remotely. I'm right now with Coastal Carolina's football team up in Niagara, New York. We're playing University of Buffalo tomorrow. But certainly when the fraternity calls, especially for issues as important as prostate cancer, I have to make it work.
Now I have to slide in for a second. I thought you said the best fraternity. What fraternity is that again, Dr. Matt?
Kappa Alpha Psi Fraternity Incorporated.
Thank you, sir. Let's hop into these questions. So I'm going to throw you the hardest question first. And it's a question that we touched on with other panelists as well, but we have a primary care physician. So why not just hop into that question with you? How do I start the conversation with my primary care physician about prostate cancer and my prostate?
Okay, so I've been seeing patients for about 25 years now, and the most common way to talk about it is the most direct way to talk about prostate cancer and prostate issues. Number one being simply, what is the prostate and what's its function? So that's the first thing that we really kind of talk about and get into. Simply stated, the prostate gland is a small reproductive gland that it's only in men. It sits below the bladder, but in front of the rectum anatomically. It's about the size of a walnut, but as we get older, the gland does enlarge. That's just common human nature, that the gland will enlarge. The function of the gland is to produce extra fluid for the semen so that it can help transport sperm during ejaculation during that process. Along those same lines, one of the other commonly asked questions is, what are signs and symptoms of prostate cancer? Unfortunately, early stages of prostate cancer, there may not be any symptoms or any signs. And so if there are signs or symptoms that are shown, some of them include interrupted flow of urine stream, frequent urination, especially at night, change in bowel patterns, particularly constipation would be something to think about prostate cancer being on the list. Painful or bloody urination or ejaculation is also involved, can be involved. Bone pain, especially hips, backs, and thighs, because prostate cancer generally tends to move to the bone if it's going to move. It can also go to lung and liver, but the bone is a common metastatic site for prostate cancer. And also urinary incontinence, unable to hold the bladder, are just a few signs and symptoms that go along with prostate cancer. It can also go with prostate enlargement too, but the talk about prostate issues should come up if any of those symptoms are in men, especially men over the age of 50, especially.
Okay. So, Dr. McIver, I have to ask you, if a patient has family history of prostate cancer, should they get checked more frequently? If so, how much more frequently?
Well, not necessarily more frequently. They should be checked more often. So when I started in medicine about 25 years ago or so, the thought was screening for prostate cancer and rectal exams starting at the age of 50. However, I started my patients at the age of 40. And especially in people that have a family history of prostate cancer, especially first degree, relative, brother, father, or even grandfather.
Now, Dr. Mack, earlier you were talking about an enlarged prostate.
Right.
What is if I have an enlarged prostate, does that mean that I have cancer? How does that play in with prostate cancer?
Okay, very good question. So there are three common situations that can happen with the prostate. Number one is something called prostatitis, which is inflammation or infection of the prostate, typically treated by antibiotics and anti-inflammatories. It can cause some swelling of the prostate, but it's not cancer. Another thing is something called BPH, benign prostatic hyperplasia, which is just the usual enlargement of the prostate gland in men. Now, like I said earlier, as we get older, the prostate gland will enlarge. In some men, it will enlarge faster than others, and that's usually when these symptoms start to happen. Again, that's a non-cancerous enlargement of the prostate. And then you have prostate cancer, which can cause enlargement in one or more of the lobes of the prostate.
So how common is prostate cancer?
Very good question, Ms. Promise. So other than skin cancer, prostate cancer is the most common cancer in men in the United States. There's close to 250,000 cases of prostate cancer diagnosed a year and greater than 34,000 deaths related to prostate cancer a year. 1 in 8 men will be diagnosed with prostate cancer in their lifetime, more common in older men and African American males, and we'll get into that a little later. 60% of diagnoses of prostate cancer are made after 65 years of age, with the most common, the average age, being 66 years of age. Now, we do know this. Studies have shown that after the age of 70, anywhere between 30 to 80% of men will have some degree of prostate cancer. So the thought is if you live long enough, all men will get prostate cancer, but it appears to be more of a slow growing cancer when you get it later in life. Additionally, prostate cancer is the second most common cause of death in men behind lung cancer. 1 in 41 men will die from prostate cancer. However, most men who have prostate cancer will live. Okay. And I want to kind of add this subset in. Like I said earlier, African American males are more likely to get and die from prostate cancer. Studies show that African American males are 1.8 times more likely to get prostate cancer and 2.2 times more likely to die from prostate cancer. Reasons why: we don't go to the physician as often as we should. So hence, if we're not going, we're not getting checked as often. Number 2, there's a genetic component to it. And number 3, there's a dietary component to it. Now, it's much more complicated than that, but those are 3 of the more common reasons why we see it that way.
Now, Dr. Mack, I know that this is a crazy question, but what actually causes prostate cancer?
Well, let's first talk about the risk factors for prostate cancer, okay? And that's the way we kind of answer that question in medicine. So I want to break this into 2 parts. One is called a non-modifiable risk factor, and the other one is called a modifiable risk factor. A non-modifiable risk factor is something that you cannot change. The most common non-modifiable risk factors are your age. If we're fortunate enough, we're going to live to get into our 40s, 50s, and 60s, which will put us at risk. Number 2, family history. There are genes that are involved in a lot of cases with prostate cancer. And once those genes and the DNA and those genes change, it can cause mutations to make you more likely to pass prostate cancer on. And the third non-modifiable risk factor is your race. Like I said earlier, African American males are more likely to get and die from prostate cancer. Those are the non-modifiable things you can't change. You can't change getting older unless you die. You can't change your family history, even though sometimes we might want to, and you can't change your race. Now, the modifiable risk factors, things you can change. You can change your dietary intake. Things like getting in more colorful fruits and vegetables are important. Things like, cutting back on the processed and red meats are important. Other things that we can modify is obesity. Losing weight can also reduce our chances of getting prostate cancer. Additionally, smoking significantly increases our risk for not only prostate cancer, but other types of cancers as well. Chemical exposure. I've had a number of patients that were exposed to Agent Orange who came down with prostate cancer. We know that is what we call a carcinogen, something that can cause cancer. Also, there's some question and research being done about recurrent prostatitis and sexually transmitted diseases that may be linked to prostate cancer as well. The mechanism we think with that will be inflammation that can be caused in the prostate by prostatitis or STDs.
So how do you check a patient for prostate cancer? What is that?
Okay. Very good question, Ms. Promise. So what we do is something called a DRE, a digital rectal exam. That's where you actually feel the prostate through the rectum with your finger. And the second way is something called a PSA, the prostate specific antigen. So in talking about checking, we'll start off with the rectal exam. You know, when we go through medical school and medical training, we're trained on how to treat how to evaluate a prostate, how it should feel. It should feel soft. It shouldn't feel hard like a rock. It shouldn't feel boggy either. It should feel more of a smooth kind of feel to it when you do that. And after doing thousands and thousands of rectal exams, you know what's normal and you know what's abnormal. Number two is the PSA, the prostate level. It's a substance only produced by the prostate. And again, when we check it, it's three ways that we really kind of look at the PSA. One is the absolute number, meaning what is it when we get it checked at that time? Ideally, we want it to be less than 4. Okay. If it's higher than 4, then that usually means that either there's an inflammation, infection, could be enlargement of prostate, or it could be, a cancer, early cancer. Again, the higher the number, the more concerning you are for prostate cancer, i.e. if you have a prostate PSA level of 10, 15, 20, that person quite likely has prostate cancer. The second thing we look at is something called the PSA velocity. That means how high does the prostate level rise from 1 year to the next. Anything higher than 0.7 is considered significant, not necessarily for cancer, but something going on in the prostate. So that warrants further evaluation. And the third way is something called the age-adjusted PSA. Simply what that means is you would expect the PSA to be higher in somebody 65 as opposed to somebody 45 because the prostate gland does enlarge, and as it enlarges, it can produce more PSA.
So now, when speaking about the PSA, if, let's say for myself, if my results come back showing a high PSA, what's the next step?
The next step from a primary care standpoint is we usually make a referral to the urologist. The urologist then sees the patient. They then reassess the patient. They may do some additional blood work. If it still is concerning that it could be prostate cancer, they then go and look at doing prostate biopsies, prostate ultrasounds to then see if it does come back cancerous or not.
So I know that with prostate cancer, you said that it's a slow growing cancer. So if one was to do a biopsy and you found that the prostate did have cancer, is the very next step surgery? What are the other options for treatment?
Okay, good question. And let me say one thing with that. When you get prostate cancer later in life, it tends to be a slow growing cancer. If you're diagnosed with prostate cancer under the age of 60, but particularly 55, 50, it's likely to be more of an aggressive type cancer. And that's when you need to really be on the ball to get evaluated. But it tends to be slower growing in the older men, 70 and beyond. So good question, Promise. What do you do once it gets diagnosed? Well, there's several treatment options. One is called watchful waiting or active surveillance, which means that you just follow that level. The urologist will talk to the patient, and often they'll come back to me as a primary care doc to kind of get a second opinion. but particularly my long-standing patients. And in some patients, you can just watch it. So if you got a PSA that's right around 5, but the person may not want anything done right now, so you can just check it. But at that point, you check the level, not every year as is recommended, but once it's elevated, we check it more frequent than that. Sometimes every 3 months, every 4 months, or what have you. So that's one method of treatment. The other one would be surgery. We call that a prostatectomy, where they remove the whole prostate. Nowadays, they do a lot of those prostatectomies robotically with a robot to do that with good success and results. Other ways to treat would be radiation, would be freezing the prostate cancer, which is called cryo, hormonal manipulation, and chemotherapy, just to name a few treatment options.
So now, Dr. Mack, when it comes down to getting a yearly physical I'm not going to say at your office, but just getting a yearly physical from your primary care physician, is the digital rectum exam done with your yearly physical, or is that something you have to ask for specifically?
It is usually done when the PSA is done. So if that's done on a physical exam, then you do the rectal exam then. Again, one part of it is just convincing males to get it done. I mean, it is invasive, but again, it's something that can save lives.
Also, Dr. McIver, I heard you say earlier that the risk for prostate cancer is 1 in 8.
Right.
Is there a certain demographic that prostate cancer is more susceptible to?
Yeah. So again, men over 60, like I said, the average age is 66, and African American males. African American males specifically have a higher incidence of getting and dying from prostate cancer. Fortunately, I can say though, the gap is closing. And I think it's because more education is being given, more people are being proactive about their health. So we are getting more people in, but it's so important to get those exams and evaluations every year. Because like I said, the PSA velocity looks at the rise from year to year. And if you skip 2 or 3 years, then it'd be kind of hard to tell when it really started, the PSA started taking off and going higher.
Now, Dr. Mack, I know we don't like talking about mortality rates and things of that nature, but what is the survival rate of prostate cancer?
Okay, very good question. So what you do with prostate cancer, and really any cancer, is you're looking at something called the grade and something called the stage. Okay, what the grade is how aggressive the cancer appears, when the biopsy. There's different looks that a cancer will have when you get a biopsy and you look at it under the microscope. The more aggressive it is, the higher the grade it is, which is worrisome. And also we look at something called the stage. The stage means, has that cancer moved from the primary organ, in this case the prostate, and is it still in the prostate, or is it moved outside of the prostate? So what we have to determine is what's called both the grade and the stage. From the grade and the stage, then you're able to kind of give an idea of survival. Now in medicine, we typically talk about survival in terms of a 5-year survival rate. So if you've got a localized prostate cancer, meaning it's in the prostate and it has not broken outside of the prostate, your 5-year survival rate is pretty much 100% if it's contained within the prostate gland. If it's regional, which means it's gone outside, but gone into the lymph nodes, but not really too far out, the 5-year survival rate is close to 100 also, but it does start to go down the more extensive it goes. But once it's distant and it's gone to bone, or it's gone to lung, or it's gone to liver, you're talking about a 5-year survival rate of about 30%. So that's why it's so important to get screened early, detected early, treated early, and often.
Dr. Mack, I thank you so much for your time today. I understand that you're on the road traveling with Coastal. So I will say chance up, even though I am a South Carolina State Bulldog, I will say chance up, and I wish you guys luck tomorrow in the game. Before I let you go, I have one last question for you.
Yes.
What are 3 things that you want to tell, because you're a fan favorite, Everybody in this area knows you. What are 3 things that you would tell your friend or just a random person about how important it is for men to get checked?
Okay, good question. And again, I want to thank you all for having me. Thank you, George, and thank you, Promise. The first thing I would say is that prostate cancer is 100% treatable and curable if caught early enough. It's 100% treatable, 100%. I would encourage males to get checked, to be proactive about it, to make sure that you're getting screened, evaluated, and that you ask questions to your physician. In this case, they're going to be the primary care physician, which is going to be first line. Third thing, I would encourage you to talk to men that you know. Just spread the word. What we're doing here with the Prostate Cancer Initiative with Kappa Alpha Psi Fraternity Incorporated, just to pass the word that this is important. It's something that is definitely treatable. Like I said, you have over 30,000 men that will die every year from prostate cancer. And so again, those are preventable deaths. Those are deaths that, you know, can definitely be, you know, taken care of. The diagnosis of it is one thing, you know, because there's just some genetics that certain cancers will pass, but it's the death rates that we have the most control over, trying to reduce, minimize. I appreciate you too. Thank you for what you're doing. Ms. Promise, keep doing well in school, as I know you will. It was my pleasure having you rotate through my office prior to going to medical school. So you take care and continue to make us all in Horry County proud. Georgia, keep doing your thing. I'm proud of you for the initiative that you've taken to take this on for the fraternity. Thank you all.
I am here with Dr. Cedric McFadden. Dr. McFadden, how are you doing today?
I'm doing well. I'm doing well. Thank you.
Dr. McFadden, can you tell us a little bit about yourself?
Sure. So I am I'm a physician. I'm a surgeon. I spend most of my time doing colorectal surgery, but I'm also a board certified general surgeon, as well as spending time at the medical school teaching those students, as well as the surgery residents that come through training to become surgeons.
Now, what is a colorectal surgeon?
So we take care of the diseases of the large intestine, which is otherwise known as the colon and the rectum. So that takes care of things like cancers. It also includes problems with inflammatory bowel disease like Crohn's disease, ulcerative colitis, and then we do a whole bunch of stuff with like hemorrhoids, abscesses, fissures, you know, all the fun stuff, right? But that's what we take care of a lot of.
Yes, sir. Thank you so much for being here.
Yeah, thanks for having me.
Let's hop into a few questions.
Sure.
We're at the portion where we talk about cancer treatments. So I guess the first question, just to stop in, what are the different stages of prostate cancer?
So like most cancers, you have early stage and you have later stages, right? Prostate cancer itself is one of the, you know, if you look at all the different types of aggressive cancers, prostate cancer is on the other end. It's generally a better performing cancer, you know, with the longer survival, which is a good thing. And the stages pretend as a part of that survival and how well people will do. So the earlier the stages, the better the survival and the better the outcome is for the patient. Stage 1, 2, 3, and 4, like most cancers, is what's used to stage prostate cancer. Stages 1, where you have tumors that are primarily associated to the prostate itself, meaning it's not spread to any other place outside the prostate. And in many of those cases, the cells look normal for the prostate cancer in stage 1. We also combine with prostate cancer numbers like the PSA and things like that that also may be really low in stage 1. As you move further up towards stage 4, that then has cancers that spread beyond the prostate involving other organs. Stages 2 involve, you know, perhaps a little bit of a larger lesion that may be felt during a digital exam by the doctor. You also may have a little bit higher numbers of PSAs present. And stage 3 is what we more or less call a locally advanced prostate cancer that may involve nearby surrounding structures like the seminal vesicles that helps make that fluid that's necessary in our semen. And so that's kind of how the progression goes. And obviously, like I said before, stage 4 is prostate cancer that's spread to, distant organs such as, bone, liver, et cetera, outside of the prostate and its surrounding areas.
Yes, sir.
Okay. What is the Gleason score and how is that used?
So the Gleason score was created in the 1960s by scientist Dr. Donald Gleason. And it's a number or scoring or grading system that really is helping to grade or to guide treatment options. It tells us the progression of a normal cell to a more advanced cancer cell. During the diagnosis process, biopsies are taken of the prostate, and the individual biopsies are all graded or giving a numerical value. Those numbers are calculated in some composition to give a number. The numbers that we see when we talk in the offices with patients, numbers from 6 to 10, lower than that are really not used in this case. But the lower the Gleason score, the better that behavior for the cancer, meaning the better for the patient. So if you have a Gleason score of 6, it's like a well-differentiated cancer, as opposed to a 10, which is going to be a poorly differentiated, which may be a more of aggressive type of a cancer. So it's used to help determine what treatment options are most appropriate and how that patient will receive treatment.
Now, Dr. McFadden, you mentioned treatment options. What are some of the treatments that are used to heal a patient with prostate cancer?
So there are many different types of treatment options for prostate cancer. In some cases, because as I mentioned before, prostate cancer is generally a slow-acting type of a cancer. In some cases, the treatment may just be watchful waiting and surveillance, meaning there's going to be no surgery involved. There's going to be no chemotherapy. It's just going to be a frequent, maybe every few months, once a year, visits with your doctor to make sure that it's not growing or that the numbers aren't increasing. But outside of just watchful waiting, the other treatment options really include surgery, which in most cases people think of a prostatectomy, and that can be done the old-fashioned way with a big open incision versus being done robotically, which is a minimal invasive technique, which really makes smaller incisions, gives a quicker return of bowel function, and it's really just phenomenal technology. I do a lot of robotic surgery, so it is actually a really nice way to offer someone surgery. But that is an option for some patients. But patients may also be offered chemotherapy. They may also be offered radiation, and that radiation may be what we call external beam radiation to the entire perineum or the area between the scrotum and the anus. They may get radiation to the whole area, or the patient may have implants inserted with radiation into the prostate itself. Other treatment options include hormonal therapy, there's immunotherapy, cryosurgery or cryotherapy. And so there's a number of other options. And ultimately, the choice that the patient is offered and then receives is really based on the age of the patient, the stage, the behavior of the tumor itself. And so you put all that into sort of this discussion with the patient and the doctor to determine, what's the right fit for you, right? There may be a bunch of options, but they all may not be the best option for the patient. And so that's a conversation that's had between the patient and the doctor about what is the best option for that particular patient.
So Dr. McFadden, I heard you say about watchful waiting, also cryotherapy. I heard you also speak about surgery. Is there any timeline for how long the treatment can take? Is there a bracket of some kind?
Yeah, so obviously surgery is a point in time that's done, right? If you're getting chemotherapy or if you're getting sort of the external radiation, that's going to be dictated by that particular course. So if you're getting, certain radiation treatments may be a session, 5 or 6 different sessions where a dose of radiation is divided over that. If you're getting seeds implanted, they may stay in for 5 years, 10 years, or whatever that time frame may be. If you are focusing more on hormonal therapy or other types of treatments, it may be such that you get that for 12 months up to 36 months. And, obviously there's so many ranges that I'm referring to because it's really individualized on the patient. It's also individualized on how they tolerate the treatment. Chemotherapy is tough. And if you're getting chemotherapy or if you're getting radiation, sometimes the time gets expanded because either the treatments become intolerable for the patient. They say, well, listen, I need to take a break. I need to, have a week off or a month off. And sometimes we have to make those adjustments. So there's so many ranges that we talk about that can be sometimes confusing, but it does show that it's all individualized for the patient.
Now, Dr. McFadden, you were speaking earlier about incisions and removing the prostate, and bowel function is one of the talking points that you said. How will treatment actually affect a person's daily life? Will they still be able to exercise, get out, spend time with their family, things of that nature?
So during treatment, things may be a little different, right? So if someone's recovering from surgery, they're clearly going to have several weeks in which they're recovering from surgery. It's like any procedure. So they may have periods of fatigue. They may have some immediate surgical type issues such as bleeding or just getting over whatever procedure they just had. If you're having things like chemotherapy or radiation, while you are receiving that, you may have periods of just fatigue where you just don't want to exercise, you don't want to rest. And on the other end, I've had patients that have had chemotherapy or radiation that continued to work, that continued to find ways in which they could do the things that they enjoyed doing. And ultimately, the restrictions are based on the tolerance of the patient and their willingness, number one, to be around others. If you're getting chemotherapy, perhaps you don't want to be around a large crowd of people where there may be other infections present. And so that determines or dictates what you're going to do with your time outside of that treatment. But when you are over that treatment, then there may be other complications that could be present as a result of that treatment.
Now, Dr. McFadden, as a guy, I'm just going to go ahead and knock out the elephant in the room.
Yeah.
How does treatment affect one's sex life?
Well, fatigue is definitely something that will lead to loss of energy. And that loss of energy can be seen not just in the ability to exercise, but also in the ability for sex. And so that becomes one of those limiting factors. But particularly with surgery and even radiation, there can be a loss of libido, there can be erectile dysfunction, and that could require other medications and or procedures to help with that. And that can be distressing for people. And that's why early on, you have to have these conversations, say, listen, you may not have the interest, you may not be able to, and even if you do, you may not be able to as long.
Now, is that something that lasts long-term effects, or is it short-term, or does it just vary?
It could be very long-term. And so when people make the consideration for, prostatectomy or surgery, that could be a long-term effect, is ongoing erectile dysfunction that requires medication or that require other procedures or implants. Technology is great. And so there are often options that people don't consider and won't have the benefit if they're not discussing this with their doctor. So I always come back to find a doctor that you can have an open conversation with, that you can be honest with, that they can be honest with you, and that you can dialogue, because the problems that you have are likely not going to be that unique to you. Someone else has had those same problems. And so there are solutions and there are options to help you get through whatever that issue is going to be afterwards. But there may be, ongoing problems with, ejaculation. There could be ongoing, and for somebody, who's, 70 or, they may not be as concerned because obviously they may not be trying to have kids. And so you can check that off the list, but in some cases that's still an issue. And so that is one of those things that people then have to say, well, listen, if I don't have the same orgasm, or if I don't have the ability to have the erection, are there injections? Are there other therapies and things that can be used that can help?
Okay. So as far as the treatment spectrum goes, what would you say the cost is like? What's the cost of treatment?
Oh, so that's a hard question, right? You start talking about cost in hospitals, it gets very confusing. Um, it ain't cheap. It ain't cheap. And we take care of patients that have resources galore and patients that don't have resources. And that's the same in most health centers. And I often refer people, if you're going to be receiving treatments, to their local hospital to look and see whether or not there are sponsorship opportunities available. Most hospitals certainly consider, and I know the hospitals that I've been employed with will have hospital sponsorships for patients. It requires some paperwork, it requires a little bit of diligence to follow through, but it is an option to help pay for some of the things that you're going to have done. There are also charity programs available that the hospitals are affiliated with that they also branch out to and also receive some resources. And now that we have the ability to get lower cost insurance through either some of the government programs, that's another option to consider. But yeah, it ain't cheap, it ain't free, but there are often ways in which you can get coverage for the treatments that you need.
Now, I know that you mentioned going to the hospital and hospital services. What about support services? Are there any support services for the patients with cancer or their families?
Yeah, so I know that the American Cancer Society, they're a great resource. They have local branches throughout the country that you can easily tap into. And I like the American Cancer Society because they really do a really good job of looking at the local resources in the area and finding the support. So that's always one of the first places that I advocate people to look for, the American Cancer Society, and finding those support groups. But the hospitals themselves have support groups. I mean, we have a support group, particularly just for people that have ostomies. If you have, problems after surgery and you're required to have a stoma or a stool bag, or you have a urine bag that you're going to have for the rest of your life, there's support groups around that. Your hospital will have information about that. Your doctor will have that. And that's one of the first things I ask for is that when you're at your doctor's office, say, where's the local ostomy support group? Where's the prostate cancer support group? Because there are going to be things locally where you are that are going to benefit you. But starting with the American Cancer Society is a good place to start, and then branch out from there.
Okay, Dr. Hall, as an anesthesiologist, is anesthesia used during prostate surgery or biopsy?
So yeah, actually, today at work there were a couple of biopsies today. So yeah, for anesthesia during prostate procedures, it can be something as minute as IV sedation, where medications like fentanyl, Versed, which kind of give you kind of like a altered mental status for the procedure or sedation, can be done as to something as much as like a radical prostatectomy or robotic prostate or something like that, where you'll be under general anesthesia. So yeah, and for that, again, you get an IV, medications to go in there to kind of put you totally under general anesthesia, and you wake up, the procedure will be over.
What type of anesthesia is administered?
It depends. So it has a couple variables there. Depends on the procedure itself, and depends on the surgeon's desire for your level of consciousness. For instance, sometimes in some like outpatient settings, they may do a prostate biopsy under sedation. Sometimes they do it fully under general anesthesia. Depends on your comfort level. Depends on your other medical comorbidities. If you have a bad heart, bad lungs, they may do it under sedation, versus a younger, healthier patient, they may do it under general anesthesia. Just it depends on your level of it depends on your level of depth that your surgeon may need you to be under anesthesia for that procedure.
So now, I'm sorry.
Go ahead. No, you go ahead.
Does the type of anesthesia influence whether prostate cancer will return, or?
So there's been no studies to my knowledge that have shown any recurrence because of anesthesia.
Now, I know a lot of us, when it comes down to talking about anesthesia, we become very afraid. As putting us to sleep, we may not ever wake up again. Can we debunk some of these myths when it comes down to anesthesia?
So first things first, most patients are more scared of me and what we do than they are someone coming to their belly with a knife. I don't understand it. They have a knife. I got something going through your IV, but you're scared of me. But it's the unknown. You've seen your cousin who had a knee replacement and they came out okay, but it's the unknown. And so everything you do in medicine, whether it's taking some Tylenol or having open heart surgery, has risks and benefits. And if anybody tells you that there are no risks, they're lying to you. Everything has some level of risks. You have to weigh your benefits with your risks. And with general anesthesia, I'd much rather have it than being yelling in pain, personally. But it's gotten a lot safer than what it had been over the years. I tell patients all the time, I'm like a chef. If you bring good groceries, my meal gonna taste good. If I got rotten groceries, I can't make a souffle out of.
Gotcha.
So it's safe. Most of it is given through an IV that someone starts, either your anesthesia personnel or one of the pre-op nurses, and that's under general. Obviously, there are other forms of anesthesia that aren't really used so much for I shouldn't say that, aren't really used for prostate cases. We have done some epidurals for post-op pain for like seed therapy for prostates. And so that's more for post-op pain than the procedure itself. And, just like a labor epidural or a spinal for certain cases is injection in your back to make your lower half kind of numb. And it's routine. We do it quite often in the hospital in general.
So now, speaking of the spinal injection, does that cause back pain or back issues or complications later on in life?
Again, like we just said, all things have risks and benefits. It shouldn't cause any long-term pain. But obviously, there have been situations in the past where there have been rare cases of nerve injury, rare cases of infection or abscess after procedures, or something called epidural hematoma, which is a bleed. But again, that is also another case of, if I'm taking a boatload of blood thinners, I probably shouldn't have that anesthetic,
right? Because
I will bleed. And disclosing your health with your provider. If you're taking blood thinners, let them know. And it's a safe anesthetic that is done all across this country for many different procedures. And it should not cause long-term sequela, but it's under the pantheon of things that happen. I tell my patients all the time, if you go outside, it's possible to get hit by a plane.
I get that.
It's not very common, obviously, but it's happened. So
when it comes down to being under anesthesia, with you being there, do you leave the room and just administer and walk away? How does that work?
So it depends on what type of model you're talking about. For most hospitals, they practice, or we practice, something called anesthesia care team model, which is we'll have either a PA or a nurse practitioner in the room, and we are monitoring 2 to 3 rooms, maybe 4 rooms, but someone is by your side from anesthesia at all times. There are certain places that do MD only practices. There's some places that basically do like CRNA, or like the nurse practitioner equivalent practices, and they're usually by your side the whole time. But again, in the anesthesia care model, which is what most hospitals use, I'm over a room, and like today, would be over 4 rooms, and I would have we call them a CRNA or AA in each room, and I'm following on the computer screen of the vitals, as well as being around for critical parts of waking up, going to sleep, things like that, going in the room. So I'm not necessarily in the room the entire time, but someone from anesthesia is in there the entire time.
So we're not just left all alone.
No, that was just Michael Jackson and Conrad Murray.
I get that. So I guess the biggest fear for myself, this may not be anybody else's question but mine.
This is just yours? Okay.
It might just be mine. In the middle of having an operation or being under anesthesia and waking up, how often does that occur? Or does that occur? Is that a thing, or is it just from the movies?
So I'm gonna give my kind of legal answer here, and and since I don't, no one in my immediate family, unlike some people I'm on the call with, are lawyers, but it when you're talking about a general anesthetic, where you're getting a breathing tube, it's basically unheard of to happen. Okay. Now, is it impossible? No. And I'll say why it's not impossible. Usually when people kind of have that feel, it's in a situation where like they're having, so it's called emergence. That you're having this emergence under anesthesia. And it usually happens in cases where your blood pressure is extremely, extremely low and you can't really get any medication because your blood pressure is so low, like in cardiac bypass and things like that, has the highest risk of it. But again, it's basically a misnomer. Under general anesthesia, it's not that. You're getting enough medication to make sure you have no memories. One of the first medication we give you kind of pause some of your memories in essence. So it really doesn't happen with general anesthesia. Where people complain of, oh, they had to give me more, I woke up in the middle of it, it's under sedation cases. And that's like a colonoscopy, right? And I kind of had the conversation with my patients. It's like a dance. You do a move, I do a move. And you kind of may make a little quick noise, I give you a little bit more medication. Not that you are having a awareness per se, or that recall per se. It's the desire of sedation isn't really going to blunt all that. It's to make sure that you're comfortable underneath that surgical stimuli. It's not taking away your surgical stimuli, right? A general anesthetic, I'm giving you enough medication to blunt any response to surgical stimuli. Under a sedation, that's not really the goal per se. And so you may hear people talking, you may hear voices. That's under a kind of sedation anesthesia that you may have that. But again, we should be giving you enough where you're comfortable and you don't feel like you're waking up with someone digging in your knee for a knee replacement.
Got you.
Right? I've been practicing anesthesia for many years now, and I haven't had nor really seen anybody with that recall that you're talking about. It's rare, especially in modern anesthesia practices.
Got you. I thank you so much for your time, Dr. Hall. You have
no
been
problem.
Helpful. I know these guys are appreciative of you. Okay, and we're back with Dr. McFadden. Dr. McFadden, we're now in the segment of post-cancer. After being diagnosed with prostate cancer, are sons and grandsons at a higher risk of being diagnosed with prostate cancer?
Yeah, so if someone has a first-degree relative with prostate cancer, so that's your brother or your father, you have a 2 to 3 times higher risk of getting prostate cancer, right? So that does increase the risk. Average age of screening from the United States Preventive Task Force is 55 to begin screening for prostate cancer. For African Americans, it is lower. It should be 45. Certainly in the 40s, Black males should be getting screened for prostate cancer. If you have a family history of prostate cancer, that's also going to influence when you begin screening, meaning looking for prostate cancer. But there is a higher risk, certainly if you have a family. But just because you don't have a family history of prostate cancer, it doesn't mean you're immune from getting prostate cancer, because most of the cases happen in people who don't have a family history of prostate cancer.
So when that family history comes, I should then get screened sooner, or how does that actually work?
Correct. So, I think, as a Black male, I would advocate screening, in the 40s as opposed to waiting to 55. And that would also portend, because of a family history, that earlier screening. Now, while prostate cancer is very rare under the age of 40, right? But if that family member was really young, that may mean screening earlier, but most times it's going to be in the 40s for you.
So, Dr. McFadden, what would you say would happen at the post appointments? What happens after someone finds out they have cancer? What does that look like, a normal doctor's appointment?
Well, it involves a conversation. First of all, we talked about being able to have an open dialogue with the patient about, and even as you're, with your doctor about what's going on, having an open, honest conversation about the symptoms you're having, complications, how you're feeling, how you're sleeping, what sex is like for you, and really having all that on the table. But it also may involve blood work that needs to be followed up. That's one of the ways in which you can see, perhaps is there something we need to be paying closer attention to? Might there be other imaging or x-rays that need to be done, such as CAT scans or MRIs? If you're having complications, that's something that's going to require other investigation. So really in that operative or that post-treatment or even just that follow-up period, it's involving a conversation, blood work, perhaps some x-rays, and just an ongoing dialogue. And that's why I can't overstress that idea of having a doctor or team that you can have an honest dialogue with about what's going on with you.
Now, Dr. McFadden, where can a person get more information about prostate cancer and the treatment options?
So there are two sources that I like, one of which is the American Urological Association. I tend to like, sites that have, science behind them, that aren't just sort of what somebody created yesterday. There's a lot of research behind. So the American Urological Association is one site that has a link with education resources for patients. But there's also a lot of information you can find at cancer.net. That's a great resource, not just for prostate cancer, but for any cancer, where you can really get into the specifics of, staging options, of treatment options, what are your risk factors, what happens after. I mean, a lot of the questions we're answering today, cancer.net has great answers to, and that's a great place to find out some of those resources for support and even financial options that you can get. So try those two websites.
And I just dropped those two in the chat. So when you're looking for this, it's in the chat. Dr. McFadden, what steps can one take to be active and healthy during and after treatment?
Well, I'm a big advocate of eating well and doing the healthy things for your body that fortunately aren't just limited to prostate cancer. I mean, we know that, if you have diets that are, low in fats, if you are having diets that are high in plant-based foods, eating the colors of the rainbow, those things are going to help you with any potential cancer. It's going to reduce that risk. And so I advocate continuing that to have a healthy life, and certainly limiting use of alcohol that can be beneficial for you, as well as if you smoke, quit. And I know that sounds very much like, oh yeah, just quit smoking, right? That's easy enough. But I really want to just say that smoking has no benefit for your health. It is detrimental for your health. It can make your recovery difficult. It can create other problems with your lungs that can make it harder for you to, bounce back after surgery. And it can really do a wonder for your risk for cancer by smoking. So that increases the ante. So those are the big things. And trying to maintain a healthy weight, having good exercise, and really trying to be as stress-free as possible, right? Imagine being stress-free in this environment. But those things really do make a difference, right? And so that's some of those overarching goals that all of us should have, not just with prostate cancer, but all of us should have those goals in mind for our day-to-day life to help keep us the best version and healthiest versions of ourselves.
So I know for a patient who has had prostate cancer, they could be worried. The first question, I would have is, what if it comes back? What are some signs that you would say to look for a person who has had cancer or cancer in remission, that they should be more concerned about?
Yeah, so it really comes back to, what are the signs and symptoms of the prostate cancer that perhaps they had initially? And some of that may include, frequent urination. They may have some discomfort when they have urination. They may notice that the urge to urinate is weak. They may even notice that the stream, once they start, is interrupted. If they have signs and symptoms of other parts of their body, such as severe back pain or headaches or memory loss, then we get concerned, are there areas of cancer that's come back outside of the prostate or the area that the prostate was in? So are we now dealing with cancer that's spread? And that's going to open up the battery for a whole bunch of other tests. But locally, or looking just in the area of the prostate, those are going to be the big things. What's happening with urination? Is there blood in the urine? Is there a new erectile dysfunction? All of those sorts of things. Those are going to bring the attention to say, what's going on? Some people might have pain or burning with urination, but those are the big ones. And they're looking at outside of the area of the prostate, what else is happening with their body.
And Dr. McFadden, you dropped some gems on us today. You've given us something to actually, for myself, being a male, to go back and look at, to start getting screened, to start thinking more about that.
Yeah.
What are 3 things that you can leave us with? 3 things that if you can tell your average guy like myself, who I'm 32, I haven't been tested yet, what is something that you can tell me moving forward with my life?
So the big one is to be preventive, right? And by being preventive, that means eating well, moving well, and sort of that overall body health. So that's number 1, being preventive. Number 2, paying attention to signs and symptoms. We often like to ignore because perhaps it's easier to ignore than to face the reality that there could be a problem. And that doesn't get you anywhere. Cancers respond better in earlier stages. So if you know you're having a problem, the sooner you recognize it and bring it to the attention of those that are caring for you, the better it's going to be for you, right? So early recognition of symptoms. And I think the third one, it's important, again, not just with prostate, but with any type of problem, medical situation, is to be an advocate, right? The questions that you've asked today have been phenomenal. And it equips you and your family when you get to that doctor's office. So you get there, you have information that you can present to them so they know you're in the game, right? They know that you're not basically passing by or taking whatever they say for granted. You're a thinking member. You're the captain of the team. So bringing your best, advocacy, bringing a family member or a friend with you that can also advocate on your behalf, it's going to go a long way for you being an active participant in your care so that you're getting the best care possible for you, right? So those are the 3 pieces of advice that I give you for today.
Thank you so much, Dr. McFadden. From the bottom of my heart, I know that everyone on here has learned a lot today. So we want to just thank you.
Thank you for having me. Thank you for this program today.
Dr. Havens, we're so happy to have you here. The first question I have for you is, what modality do you use when it comes to naturopathic medicine?
So I use integrative oncology, and integrative oncology is really a marriage of naturopathic medicine and conventional medicine, where we use all the naturopathic modalities to support patients as they are getting treatment with their conventional therapies and, help boost the efficacy of those therapies. But I don't ever use naturopathic medicine as a standalone intervention because it really works best combined with conventional therapies and gives patients the best outcomes.
You explain what naturopathic medicine is?
I absolutely can. So naturopathic medicine is really an umbrella of a lot of integrative modalities that have been around for centuries. Naturopathic medicine varies somewhat based on whatever state that you encounter a naturopathic physician in, because our scope of practice is different. But naturopathic medicine, we have our therapeutic pillars. We're teachers, we don't do any harm. It's very similar to conventional medicine in that regard, but it's really using the body's innate ability to heal itself is really one of our guiding principles as a profession. And how we do that is where we really differ because of the modalities that we can employ. Sure, we can employ some of the things that conventional doctors use, antibiotics, steroids, minor surgery. Physical medicine is in our scope of practice, which is not, unless you're a DO. We've got nutrition. Nutrition is one of our pillars. It's really important. And we can turn around a lot of disease just by changing our diet. Diabetes, prostate cancer is one of the things you can turn around with diet. Even breast cancer, we can reduce the risks with breast cancer, colorectal cancer. A lot of the cancers have such a prevalent dietary component to them. So nutrition, one of our pillars there. We've got acupuncture. In Arizona, we have the good fortune of having acupuncture as part of our scope of practice, which is amazing. Traditional Chinese medicine is remarkable. I don't feel like I feel like I could train in acupuncture for another 10 years and still not know all that I need to know in the traditional Chinese medicine realm. Botanical medicine. So many plants that do so many things. I use botanical medicine a lot in the integrative oncology realm. Obviously, we take, specific constituents out of the plant, use them a little bit more therapeutically, but botanical medicine is in our scope of practice. Homeopathy, I love it. Homeopathic medicine is amazing. And unfortunately, because of the nature of its efficacy, the FDA has been challenging and trying to remove our ability to prescribe homeopathic medicines, which is unfortunate. But we have a lot of these modalities. Hydrotherapy is in our scope of practice and amazing. Our body's made up of over 70% of water, and we can use that water to shift disease processes. So it's taking our body's innate ability to heal itself and then using all these great modalities that have been around for so long as tools to help support that.
Dr. Havens, what does the intake process look like for a patient who has prostate cancer?
Actually, it looks very similar to what they would encounter in a conventional setting. But I think probably on my side, I actually end up doing a lot more visiting about their conventional therapies, because oftentimes when patients get a diagnosis of cancer, I call it the bullet train. Once you get the diagnosis, then everything moves very quickly. All of a sudden you have all these doctor appointments with medical oncologists, radiation oncologists, surgical oncologists, all the other care members that are involved in those teams. And patients barely get a chance to even consider the fact that they just got this very, very scary diagnosis, let alone have any chance to let it sink in and understand things that are going on. And then oftentimes what goes along with that is that those patients, they don't get to have conversations with these providers. These providers just say, you know what, this is your diagnosis. This is what we're going to do. You're going to go here, A, B, C, and D. You're going to get this. You're going to see this person, and we'll see you at the end of this whole process. And that may be in 6 weeks. That might be in 2 months, but they don't ever have a chance to really even understand what's happening to them. So oftentimes, I'll ask very similar questions to what their conventional medical providers would ask, but then we just have a lot more of a conversation about what's happened to them. You have this diagnosis, you've just gotten a diagnosis of prostate cancer. What does that mean? What does that mean for you? Are they recommending that you get surgery? Are they recommending that you get systemic chemotherapy? Are they recommending that you get radiation? And how is that going to impact you? What does that look like for what's going on in your life? How are you going to continue to work? Are you going to be able to support your family? Are you going to get tired? Are you going to get sick? All those things that they don't really get a chance to talk about with their regular conventional physicians. So it's really more of a dialogue, I would say, than necessarily an intake, because it's a chance for patients to have a conversation about what just happened to them, because they really oftentimes will only get maybe 10 minutes with their conventional providers, which isn't even enough to scratch the surface of getting a diagnosis of cancer.
So that's beautiful. So what would you say like the overall difference would be as far as naturopathic medicine to regular Western medicine? What would you say the difference is?
I would say from a higher level, it's really just more supportive. Naturopathic medicine is about patient-centric medicine. It's patient-specific. When a patient comes in and they have a diagnosis of prostate cancer, no two patients are the same. I like to say that every cancer is like a fingerprint because it really is unique to each patient. Even though it might have the same name as prostate cancer, that doesn't mean that every single patient looks the same. They don't. Every single cancer is different. It's different at a genetic level. It's different at a physiologic level, and how it manifests in each patient's body, and how a patient responds to that therapy is very, very different than any other patient. So it's a very patient-centric, supportive intervention for patients.
Dr. Haven, what is the importance of alternative medicine and its place when it comes to treating patients?
I would say it's never alternative. It should always be integrative, because really there's not enough data to support only using natural interventions to treat cancer. It's just not there. You know, as a naturopathic physician, I'd love to say that you could juice 20,000 carrots a day, not eat any red meat, and exercise and sleep right, and we can cure your cancer. But unfortunately, that's just not the case. Our therapies are great, they're strong, but they're not strong enough in the sense that we can eradicate cancer. You know, in prostate cancer in particular, if you have an earlier stage cancer, we have a lot more wiggle room. You know, our therapies are a lot more impactful than if you are a stage 4, obviously. But still, it's really, you really need both. That's just what I've seen. Really, when you went, if a gentleman came into my office and he's got a, you know, a stage 1 or stage 2 prostate cancer, his chances of medicine more successfully are much greater than if he comes in as a stage 4. Because at that point, when you have a later stage cancer, and it's not just specific to prostate, it's oftentimes with all the cancers, our treatment options and efficacy of those therapies are pretty limited, because the disease has gone way beyond what the body can deal with at that point and reel back in. But certainly the earlier, the better. Our interventions are a lot more impactful when they're earlier stage. So diet has a lot more impact. In fact, specific for prostate cancer, there's a diet, it's called the Dean Ornish diet, that's very impactful. And the data has shown that for early stage prostate cancer. So things like that, they work a lot better when, you know, guys are getting their yearly checkups and finding things early and coming in and using all the therapies integratively and conventionally to have the best outcome.
Dr. Havens, can you explain that diet a little more?
Yeah, the Dean Ornish diet, it's was formulated by a physician, Dr. Dean Ornish, and it's really mostly a plant-based diet. It's, you know, basically what you would expect, you know, eating lots of fruits, lots of veggies, decreasing your red meat, very little red meat, if any, in that diet. In fact, mostly it's just a little bit of fish and a little bit of chicken and eggs, but mostly plant-based protein. And that data has been shown scientifically to help reverse early stage prostate cancer. So it is something that I typically recommend for the earlier stage prostate cancer patients. And he has a website you can go to, and it, you know, they've got all the data on there for gentlemen that want to take a look at the diet. And he pretty much outlines it well on his website without you having to buy anything, which is another reason I like it. But it's pretty straightforward.
And that website will be linked in the chat.
Okay, perfect.
Okay. Would you also recommend that diet for preventative care? If not, what would you recommend for?
Absolutely, especially since it's had such a good track record for prostate and early stage prostate. You know, obviously that in conjunction with getting your regular checkups and going and getting your blood work and all those exams, it's really not any different than any of the other cancers. The earlier that you can catch something, the better your outcomes are going to be. And that's really true with prostate as well. And so I think there's this misconception that it's prostate cancer. You know, it has this, I think, kind of a association attached to it that it's a slow growing cancer, and most people don't really take it as seriously as they should, because, you know, all cancers, if left unattended, they'll get away from you. So, and certainly, you know, in men, and traditionally those guys don't like to go to the doctor. They don't really like to get checkups, and they certainly don't like to get digital rectal exams. That's, nobody's signing up for that, right? They're not lining up to get in line to get that done. But it's really the best way to catch things at the earliest time.
Now, are there any specific supplements that you would suggest a patient with prostate cancer take?
Not necessarily. The realm of supplements is kind of complicated, specifically for prostate cancer. And a few years ago, there was a paper that came out. There was a study where they were looking at selenium and vitamin E, specifically in patients that have prostate cancer, because there had been this recommendation, and it was made around the early 2000s, that if you supplemented with vitamin E and selenium, it reduced your risk for prostate cancer. And that study really demonstrated very nicely that you really can't say that, because really what they discovered is that you needed to see what a patient's baseline level of those nutrients were before you started supplementing. Because oftentimes what the data shows is that if you've got a level, that's a normal physiologic level, which is safe, and then you start supplementing, that doesn't always necessarily send you in the right direction. What they saw is that if you had a good physiologic level of vitamin E and the selenium, and then you went ahead and supplemented, that actually increased your risk for prostate cancer. So recommending supplements is a little bit more tricky and dicey. And it's the same case for vitamin D. Vitamin D, there have been numerous studies that have shown for all-cause mortality that good levels of vitamin D are really important to reduce all diseases. And there have been numerous studies that have just been ongoing over and over again. They show that vitamin D is really, really important. But really, you can't recommend supplementation with that until you get a vitamin D level. And historically, vitamin D levels are pretty low for most people, simply because it's not something you're going to easily get from your diet. But again, if you want to supplement, you always want to go and get the blood test and make sure that you have the right amounts.
Where can a patient find resources to treat their cancer if they prefer naturopathic medicine?
Resources in terms of providers, or resources in terms of online information?
Can we start with providers and then move on to online information?
Sure. So for providers for prostate cancer in the integrative realm, you can always go to the NCCIH, which is the National Centers for Complementary and Integrative Health. They have ongoing studies it's the NIH's branch of integrative medicine. And they have ongoing research studies for a lot of different aspects of integrative medicine. So you can always find studies there for specific providers. In the naturopathic oncology realm, we have a naturopathic oncology association, the ONC-ANP, and that's we can also get that link for you guys to put in the chat as well. And that will give you a list of naturopathic physicians that specialize in oncology in each state. So that's always a good resource. And then also the Society for Integrative Oncology, which is SIO. They also have the same sort of provider links that you can find in each state, providers, both MD and ND, that specialize in integrative oncology. So those are two really good resources. And I'm glad you asked the question, because a lot of times patients don't know about those unless they already have a naturopath in their pocket. So that'll be a good resource for them wherever they are in the United States to find a provider in the naturopathic realm that specializes in oncology.
Yes, that kind of touched base on my next question. I was going to ask you about, as far as naturopathic medicine, I know that for different treatment options, some places it's really hard to find like acupuncture or the different modalities that we really use. I wanted to ask you if there's a certain location they can go to receive whatever type of treatment that they're looking for.
You mean in the United States?
In the United States.
I would have to say probably here in Arizona, Arizona is the best. Probably second to that, I would say Seattle or Washington State. And those are both states where naturopathic physicians are licensed. It's also states where integrated providers as a whole have the best scope of practice. Hands down, Arizona, Washington State. And pretty much you can get anything, any integrative provider that you can dream up, you can find them in Arizona.
Now, Dr. Haven, what are 3 tips that you would share as a naturopathic physician as for men's health?
You know, like I said, getting your annual exams. That's so incredibly important, especially for African Americans, because prostate cancer is much higher. It's has a higher prevalence in African American populations. So I can't stress that enough. Again, those regular exams, getting your PSA checked, getting your DREs, and just your general health, getting your blood work, for sure. Absolutely, hands down, one of the best things you can do. And the other thing is diet. It's so important to eat right. And it's hard. You know, even as a naturopathic physician, it's hard for me. I don't eat great all the time. You know, especially when you travel. There's so many things, especially now, we're living in the age of a pandemic. Uh, people have been at home, just sitting around, not eating great. So diet's really important. The Dean Ornish diet specifically, like I said before, for prostate, 100% recommend that. And then the other thing is to move. You got to move, exercise, time and time again, and not just for prostate, but for pretty much all the cancers. 20 minutes a day, if you can just move, even if it's just walking. Obviously you're going to get some cardiovascular benefit from that, but just the act of moving and moving your lymphatics and moving your blood and oxygenating and breathing and all the things, so incredibly beneficial. And it's, like I said, 20 minutes. We can all find 20 minutes to even just get out and walk around, especially now in Arizona when the weather's going to start getting nice. Get out, get some fresh air. And they seem so basic, but those are really, nothing's changed from when our grandparents said, we got to eat right, sleep right, and move around. It's really the same thing. Get your exams, have a good diet, and move, exercise.
That was beautiful. Thank you so much, Dr. Havens. I really do appreciate you being here and being on the panel.
Absolutely, promise.
Hi, I'm here with Mr. Keith Cox, who is a cancer survivor. Mr. Cox, how are you doing today?
I'm doing great, young George.
Can you tell us a little bit about yourself?
First of all, my name is Keith Cox, and it's a pleasure that young Mr. George asked me to do this for him and his fraternity. It's always a pleasure of mine to tell our young African American men and African American men to go get checked, first of all. And there's nothing to be afraid of to being checked. We need to be checked. And I stress that so much to our people, our guys, because we need it. I work at Combraco for the last 35 years since high school. Been enjoying my job, been a supervisor for the last 7 years, and I try to help many young African American guys to come be employed, regardless of what they're doing. And we all know that we have our young guys that's in trouble. So my job and Combraco's job is try to help as many as we can. And I really appreciate my HR for giving me all the leeway of bringing guys in and trying to get them off the street and everything.
Yes, sir. Now, Mr. Cox, we're here today talking about prostate cancer awareness. And we're trying to make sure that everyone understands, not just from the doctor's standpoint, but also from the patient standpoint. So, Mr. Cox, what type of cancer were you diagnosed with, and when did you receive your diagnosis?
I have diagnosed with prostate cancer and lymphoma 13 years ago on August the 8th. Yes, 13 years ago, August the 8th.
So you just had, I guess it's a cancer anniversary, because August was just around the corner.
Absolutely.
Now,
Absolutely.
what were the events that led up to your diagnosis, or how did you discover that you were suffering from this cancer?
Thank God that Combraco give us an annual checkup, because quite well, Mr. George, that we as African American men, we don't go to the doctor.
Yes, sir.
Like we should. But thank God that my job gives us an annual checkup. And when I did, they realized my PSA was a little high. Then normal for my age at 43 years of age, and it was a little too high. My PS was SA level was high, level of a 65-year-old.
Yes, sir.
So right then, and I talked to a couple of friends of mine, Kenneth Robinson, Kenneth Dixon, and they like, man, you might want to go get this thing checked. So I did. Went to see a neurologist, Dr. Woods in Conway. and they ran checks on me for about 3 months. So, and that's when they determined I had prostate cancer.
Now, what was your first reaction when you were told that you had this form of cancer?
I'm gonna die. I began to cry, and at the time, and me and my girlfriend Denise was in the room. Whenever Dr. Woods came in the room, to let me know that I was diagnosed with prostate cancer, and immediately I began to think about so many great guys in Horry County, Porter Johnson, Pistol, Generate, so many other guys who died from cancer. And so my immediate reaction was, I'm gonna die. So, and Dr. Woods just looked at me, kind of like dropped his head and walked out. So I'm just give you a minute, you know. But immediately, many of us, we think of death. We hear that word cancer. So once I heard that word cancer, I immediately began to think I'm gonna die. And the worst feeling is to be able to have to come back and tell my son what my situation was. And if anybody know me and my son, we are very close. And of course, my son passed last September.
Yes, sir.
And news he didn't want to hear. He was frightened for me, but I was frightened more of per se of leaving him. But I began to just accept the fact it is what it is. So.
Mr. Cox, how was that conversation to tell your loved ones that you were diagnosed with cancer?
It was tough. It was tough. They began to cry because, like I said, we all know so many people that die from cancer. And first of all, we always think of death immediately. You know, let's go ahead and plan for gatherings and all that, because he's not gonna be here much longer. You know,
yes,
but they begin to cry, and you can see the pain in their eyes. And I tell anybody the worst thing of all is to be able to tell your kids, especially they're adults and they already know about cancer and everything.
yes,
that's the worst fear of all, is telling your kids that you have cancer.
Now, obviously, cancer put your life on hold. Do you remember the specific moment when that realization hit you that I have cancer?
A week after I was diagnosed, and the doctor told me, when I went back to work, I realized, you know, I have cancer. What I'm going to do about it? What can I do about it? What can I do to help me? So I immediately began to start quote scripture and said that, you know, I will not die. You know, I'm not going to die. You know, because he said all sickness is not to death.
Yes, sir.
I had to remind Christ that he said it. I didn't say it.
Yes, sir.
In his word, he said all sickness is not to death. So I began to quote that scripture immediately, day in and day out, day in and day out, day in and day out. Continue to just quote that scripture. No other scripture but that one. Lord, you said all sickness not to death. So
yes,
I refuse to die. And so at that point, I began to just relax, you know, live life and continue to move on.
How long were you in your treatments? How long did the treatments take? And what helped you and help your spirits as you went through this period?
For the first 7 years, 8 years, my numbers was undetectable. I was able to skip chemo and everything because my number was undetectable. And then you have to go to your doctor's appointment. When they say come tomorrow, you need to go tomorrow. They say come Monday, you need to come Monday. But you always got to stay on top of whenever you are diagnosed with cancer. And that's what I chose to do, is stay on top of mine. And so I decided, you know, went to my doctor's appointment, and they told me a word that nobody want to hear. These words here: you got to have chemo. Your numbers have spiked. You need chemo. You know, hope that chemo will take care of this problem. So I said, let's go and ride. And at that time, Mr. Young George, I done accept the fact it is gonna be what it is gonna be. You know, my life was, I was okay. So I did chemo for 5 months, 4 days out the week. Up there in Charleston, had some great doctors, Dr. Navarro and Dr. Card. But first, also, young Mr. George, I want to say Thank you for a family of mine, the Draytons, Damian Drayton and Landa Caper, and their family, who put me up in Charleston for 5 months.
Yes, sir.
And took great care of me. Whatever I needed, they provided. Mother Maggie left loans and moved to Charleston for those 5 months to make sure that she fed me every day. So I want to make sure I give them the proper respect.
Yes, sir. Yes, sir. Wow. Wow. So, Mr. Cox, while you were going through chemotherapy, what did you do to help you meet the challenges? Because I can't even think to start to imagine, but I hear that chemotherapy is tough. What did you do to help get you through that time?
Pray and believe and trust in my son, because I want to make sure I watch my son grow up.
Yes, sir.
And become a father. I wanted grandkids, and but also my appetite. I never lost my appetite. And the reason why I didn't lose my appetite, young Mr. George, is because Mother Maggie moved to Charleston to feed me every day.
Yes,
when I came from chemo, after 6 hours of chemo each day, she had me a meal ready, whatever I wanted to eat, chicken, pasta, whatever. No matter what I want to eat, Mother Maggie Capers had that meal prepared for me.
Yes,
so I definitely want to give her a tremendous shout out for taking care of little old me. And Landon, Damian, and Jay and Lowe in London was there to cheer me on every day. So I cannot thank them enough what they done for me. And the doctors also said the good thing about me is that my appetite was so strong versus so many other people that was going through chemo. They lost their appetite, were losing their weight, losing their hair. Of course, I don't have any, but they was kind of like, how the word I'm looking for. They was kind of shocked that I haven't lost my appetite. Like they were asking me questions, why haven't you lost your appetite? Most people with going through chemo lost their appetite, and it goes back to my trust in Christ, my belief, my faith, and the Capers and the Drakes for taking good care of me, and making sure I ate from the very first beginning of chemo. And I do truly believe that once I began to eat after that first treatment, my body took a great response to it. So that's why I think that my appetite was so great.
Now, did you have any side effects while going through chemotherapy? I know you said that you didn't lose your appetite, but were there any other side effects?
Oh yeah, you're tired, you want to sleep. You try to push yourself because that's what you're known to do, is pushing yourself before you become ill. So me thinking that I'm not ill, I'm steady pushing myself, trying to stay up longer than I should, and knowing that my body is tired. I want to go to sleep. And I also want to say to the young man, African-American man, listen to your doctor. What I'm going to tell you guys is going to send a shockwaves to you guys, okay? But listen at your doctors. I chose to have my prostate removed versus keep my prostate and die.
Yes, sir.
Let me repeat that again. I chose to have my prostate removed in order to keep my prostate and die. So my doctor, he told me, I had a great doctor, Dr. King and Dr. Carl are really great. And I asked him, the question was, if I have my prostate removed, what are my chances of having a long jet of living? He said, long. He said, but if you keep your prostate and it come back, it's going to be difficult to stop it. Then it's your choice, but you got to decide, do you want kids or do you want to die in a few years, probably?
Yes, sir.
So I chose to have my prostate moved. And of course, we as African-American men, we think doctors are pride in our personal space per se.
Yes, sir.
We have a real talk, right?
Yes, sir. Real talk. Yes, sir.
Okay, we as African-American, we feel violated, per se, if the doctor do a finger wave on us, whatever.
Yes, sir.
Forget about that finger wave because you know who you are. That's number one. You know who you are. Also, you want to live. And if you have kids, especially young African American, if you have kids, you want to see your kids grow. So therefore, you go to the doctor and continue to get checkups, and they tell you we need to do a finger wave, then let them do a finger wave.
Yes, sir.
You know, don't be afraid, don't be shy or trying to say somebody violate your rights or whatever, because they're not. I'd rather for men to violate my rights than me die at a young age.
Yes, sir.
And I tell all young men, go get, if you got a job and got good insurance, go and get a physical. They tell an African American man to go get a physical at the age of 40 for prostate. I tell them, go at age 19 when you become a young man and get a job, get on the workforce. You got health insurance. Go then.
Yes, sir.
And once you go, just constantly go once a year. They continue to get that checkup, because prostate is not just hurting older guys now. You hear tell young guys is being diagnosed with prostate or colon or some type of cancer. So as long as you got a job, as long as you got insurance, use it. Use it, use it, use it. I promise you it'll benefit you in the long run.
Mr. Cox, did you join any type of support system when going through chemotherapy or going through prostate cancer, having prostate cancer?
No, sir. On the group I joined was Christ himself.
Yes,
and
sir.
I had some of the best friends in the world. Yeah, some of the best friends in the world. None of them, they was not sugarcoat. A few of my best friends was Robert Capers. I cannot say enough about him. Him and his family. This man and his wife drove down from Maryland the weekend before my surgery and stood by me from that day forward to this day. Then you had the Robinson family, who stood by my side from day one. The Jackson family, Mike Jackson and his family, Michelle, Bellamy, the Draytons, my family, the Browns, the Steels, Mr. George. I tell you what, I tell people all the time, in this world, you're gonna need somebody. And those who don't think they don't need nobody, they fooling themselves.
Yes, sir.
We all need somebody, because whenever you down and out and you in that hospital room and you ain't got nobody visiting you, you wonder why, where is people at? Why I ain't got nobody come see me? You got to ask yourself a question. What have I done in my life to create this mess where nobody don't want to come see me? We all need somebody in this life, because when you sick down, Mr. George, you want somebody to come out, if not just to shake your hand. So I give that group of people, Nuki Brown, it just Cheryl, Dr. Spain, my church family, Hills Chapel. I give them, and my beloved pastor, Reverend Charlemagne Johnson. I give these guys so much credit for being there for me, helping me walk through my journey, my job, my boss. They really been supportive of me. They've been right beside me. Days I need to be off, no question asked, take off. And if I left anybody out, I really want to say thank you. I do apologize, but I tell you, Mike Bellamy, man, just the list goes on. That was my support group, those who I named out, and there's many more. The strikers, just many people were there for me. That really supported me. A young man by the Paul Mishu, who lost his life 2 months after my son lost his life. Elijah Crawford. These guys was like kids to me, but they felt my pain, and they stood by me the whole time. But God is good. He's good, very good.
Now, Mr. Cox, you mentioned your job. Were you still working while having treatments?
Yes. I had to take a leave of absence for 5 months while I was taking treatment, because of me taking treatment in Charleston 4 days out of the week was just really too much. Try to come from Charleston and try to work. It wasn't benefit me nor the company, So I truly say thank Combraco for working with me while I was out for those 5 months.
Now, Mr. Cox, we always say that hindsight is 20/20. Now that you are a survivor, looking back on how you went to the doctor and things of that nature, is there anything that you would do differently?
So yes, I would not wait for just my job to give me a physical. I would begin to go to the doctor and get my own physical.
Yes, sir.
You know, I you know, some of I have created myself because I should have went to the doctor myself and got physical way before the 13 years. You know, I can say it now, but I couldn't say it then. But I should have been going to the doctor then instead of waiting till my job created the physical.
Yes,
And if
sir.
I would have been going 20 years prior to that, who knows would I have ever went through this? You know, maybe not. I don't know. But I should have taken advantage of the insurance that Combraco had offered me 20 years ago. So I want to make sure everybody else knows. Take advantage of it. Don't just wait till a company give you a physical. Do it. Hey, do it. Go get your own physical. You got insurance. You know, all you have to pay is copay. So just go get it done. You know, don't just wait till your job offer you a physical. It could be too late.
Now, Mr. Cox, how are you living your life differently now after being a survivor?
I live no different. I live no different. I still go out and have fun. I just asked my doctor the question. I say, now, can I ride my motorcycle? You know, because they say motorcycles create prostate because of the ride, the bumps, and all that stuff.
Yes, sir.
So I said, can I ride my motorcycle? You know, we got a battle now. If I can't ride my motorcycle, something got to give.
Yes, sir.
And he said, no, you can't ride. You
Yes,
can
sir.
ride. So I live my life no different. But what I do, you know, Mr. George, I try to treat people the best I know how. I try to give as much as I can give to people.
Yes, sir.
Not trying to look for anything in return, but I try to give to people. I try to help people. I want to help people. I try not to walk around with a mean spirit because it has taught me that death is you can't get by death.
Yes, sir.
And sickness is going to come upon everybody.
Yes, sir.
You know, sickness is going to come upon everybody unless death catch you first.
Yes, sir.
So I try to live my life as have no hate, no animosity towards nobody. But of course, some people and I do have disagreement. We don't speak, but I don't have hate in my heart because the Bible says sometimes you just have to take dust off your feet and walk away.
Yes, sir.
And that's what I do. Per se, to stand there and cuss a man out, which is not right. So I just stay my distance from people that we have issues with. Let's put it like that, because we all have issues with somebody. So if anybody think they don't, except again.
Yes, sir.
We all have issues with somebody. But
yes,
the main thing, I don't want to walk around with so much hate in my heart against any man, because we all know that death is unknown to man. You live in this moment, and next moment you dead.
Yes,
so
sir.
I don't want to be led up there, somebody trying to talk good about me and knowing that I done did wrong to so many people. So I try to live the best I can. Yeah.
Now, Mr. Cox, throughout this whole conversation, you've been dropping gems on us left and right, telling us to get checked and these different things. What are just three things that you will tell a person who just yesterday learned of their cancer diagnosis or who is afraid to go to the doctor right now?
The three things I would tell somebody who's diagnosed with cancer: don't look at as though you're going to die. Look at it as you're going to live. Number two, make sure you start cleaning around yourself. The things that you got going wrong in your life.
Yes, sir.
People who you mistreated in life. Make sure you regain your family values if you have lost any. Get that in order. But not to be afraid to die, but yet live and be happy while you live every day. Make sure every day is like your last day. In other words, love people, love yourself, love people, love your family, treat your family the best you know how, treat people best you know how, and just live. Don't look at, I got cancer and I'm gonna die. Just live. I don't look at no more young Mr. George as though I'm gonna die. I live.
Yes,
I
sir.
live every day and I live. I live. I try to be happy at all times. I'm still the comedian that I used to be. I just live, and I tell anybody, live. Just live. Just live. Enjoy your life. Don't look at it as though you got a death sentence. Don't look at it like that. Just live. That's it. Just live. Live your life the best you know how. Treat people the best you know how, and to love as much as you can, and make sure you take care of your family.
Yes, sir. I thank you so much for your time, Mr. Cox. I thank you for not being too selfish to tell your story to us out here watching today. This means a lot because as African American men, we don't go to the doctor. That's the very first thing. As the participants have heard earlier, that one of the doctors said we don't go to the doctor until that check engine light come on.
Mm-hmm.
Then you go to the doctor. So I thank you for not being selfish and just telling us everything that went on with you and being open and free about it, because that means a lot. We as men, we don't talk about things like this. That's the reason for this real talk today. So
That's
I
true.
thank you so much.
And one other thing, Mr. Jordan, I do want guys to understand. Guys, listen at me good. If you ain't heard nothing else I say, I want y'all to listen at me good. We all know that prostate is lead up to our erection system. You're gonna have problems with that. You're gonna have problems with that. Forget about that. Forget about you're gonna have problems. They got medicine for all that stuff. Your major concern here is to live. I want to live. I'm going to live regardless of the situation, whatever. I'm going to live. So don't let that get into your mind of you about your erection system. It's going to affect your erection system, whatever. You want to live. So as I did, I chose to live. So whatever else take place, it's okay. But you want to live. And again, young Joy, I truly appreciate you for thinking about little old me to ask me to do this for you. And it was a pleasure of mine. Anytime I get opportunity to speak to young men about prostate cancer, colon cancer, whatever, it is a pleasure of mine, because I do want our people to go get checked so they can have a healthy life and to take care of their family, their kids, because we do know our young men need their father in their life. Our young daughters need their mothers in their lives, and they need their fathers as well. So I truly thank you, and I appreciate you. And to all those who stood in my corner for the last 13 years, I cannot tell Denise Stackhouse, and I can't say thank enough to her for being there for me from day one. I just truly thank those who've been in my life, Cheryl Brown, Dorothy, and like I said, Robert, Kenny, Mike Jackson. Those guys was awesome to me. I mean, at that time, they had me spoiled. I ain't want to get well.
Yes, sir.
But I do think those guys, man, the Draytons and all, man, I tell you one thing they did, Mr. Joe, I'm gonna let you go. When my chemo was over, they had Damian and Lana put on this big old cookout up there in Charleston. I'm talking about huge. Invited everybody to come. I'm talking, no matter where you were, come. We celebrate their brother, which they call me their brother. And they celebrated. Damien and Lana cooked all this amazing food, and my family from here and my family from Rob and all them came up to Charleston. We had a magnificent time, and all we did was we were just fellowshipping together and giving God thanks for allowing me to be able to overcome my chemo. But I'm doing good. And like I said, I continue doing my checkup every 3 months. My numbers are still small, so by God's grace, I'm still doing good. I'm doing better than good. Like I said, 13 years, and I'm looking to see 13 more years.
Yes, sir. And I'm Mr. Cox. You said you've been giving me scripture earlier. So I thank you, because the Bible says that death and life is in the power of the tongue. So
Amen.
Thank you. Thank you for choosing to live.
Thank you so much.
Your choice to live, you're here to talk to us today. So I thank you for that, Mr. Cox.
Thank you so much, Mr. Joy. Y'all have a great day.
Ladies and gentlemen, I thank you so much for coming out today. I thank you for your time. I thank you for everything. So let's start off with our panelists. I want to thank Dr. Hall, Dr. McIver, Dr. McFadden, Dr. Havens, and to Mr. Cox, because they devoted their time to Kappa Alpha Psi today to spread information about prostate cancer awareness. Ms. Promise Scott, I want to thank you. I reached out to you and you said, great, let's do it, let's go. Thank you so much. Now, in the words of my mom has a saying that you could have been anywhere in the world, but you decided to log on and join us today. So I want to thank all of you for coming out today, because you could have been anywhere, but you decided to be here with Conway Myrtle Beach Alumni Chapter of Kappa Alpha Psi Fraternity Incorporated. Now, if you're not following us on social media, follow us on Facebook. Our Facebook handle is Conway-Myrtle Beach NUPES. That's on Facebook at Conway-Myrtle Beach NUPES. On Instagram, it is CMB_NUPES. That's CMB_NUPES. We have a lot more things planned for the rest of this year. Follow us. Find out what's going on. Come participate. Now, I see that there are a lot of women who are on here right now. So I ask that you get this information out to your husbands, your friends, your neighbors, your sons, because all men need to hear this information. This will also be posted on all of our social media sites. Please share it. That way this information can get out. I thank you for your time. And on the flyer, I said 2 o'clock. It's actually 1:34. So I hope that you enjoy the rest of your day. I know that I had a friend from Japan on here earlier. So I will say to him, if he's still on, have a good night. And I'll see you guys later. Thank you.